Hello everyone. In this class, we are going to discuss only about selective alpha 1 blockers. Okay, we'll be paying more attention to alpha 1 blockers. Okay, now before we go into blockers, we must know what alpha 1 receptor does, right? So, alpha 1 receptors, when it is present on surface of smooth muscles, it causes smooth muscle constriction. Okay, smooth muscles to contract, right? So, alpha 1 agonism, right, stimulation causes smooth muscles to contract. Okay, contract. Now, so if it is the smooth muscles are present in your blood vessel, and if alpha 1 receptors which are present there are activated, what will happen? They will contract, resulting in vasoconstriction. Okay, that will cause what? Vasoconstriction. Now, just think what will happen if the opposite happens. If alpha 1 receptors are blocked, what will take place? Vasodilation, because smooth muscles now will what? Relax, right? So there will be what? Vasodilation, right? And if vasodilation takes place, what will happen to your BP? BP will fall, right? So BP will fall. Now, in which case you want your BP to fall? When you have what? Hypertension, right? So the major use of this class of drugs is what? To treat hypertension, right? So which drugs do that? Prazosin, terazosin, doxazosine are the major drugs used to treat hypertension, right? Now, what is the side effect? Side effect is because it has the potential to cause hypotension, right? Decrease BP, it can cause orthostatic hypotension. Another term for orthostatic hypotension is postural hypotension, right? So what is that? It is the decrease in BP that you see when you change posture, right? For example, if somebody is lying down and they sit suddenly, or from a sitting position, you stand up, what will happen? The BP will fall. That is called orthostatic hypotension, also called what? Postural hypotension. Hypotension that takes place when you change posture, right? And that can cause what? Dizziness, and the patient may fall, right? And if the person is elderly, it can result in what? Fractures. That's why it is dangerous, right? Now, so among these three, doxazosine is considered the longest acting drug, right? Now, they have a favorable effect on lipid profile. What does that mean? Favorable effect means they will increase the cholesterol that you think is good, right? And decrease what you don't need, right? So HDL, we call it what? Good cholesterol, right? And we call LDL a bad cholesterol. Why? We will look that in the chapter on hypolipidemic agents. Okay, right. So HDL, good cholesterol increases, LDL, bad cholesterol decreases, right? When you give these drugs, right? Now, these drugs are third line treatment for hypertension. So what is the first line? It is thiazide diuretics. Okay, so among diuretics, thiazides are the ones that are preferred for treating hypertension, right? Especially low dose thiazide diuretics. Now, in case of pregnancy, it is different. We usually go with methyl dopa, right? Because long-term use of methyl dopa is not good. So pregnancy is not a long-term condition, right? It only lasts for 9 months, right? So methyl dopa is the one that is preferred in pregnant women, the first line drug. Now in hypertensive crisis and all, we usually go with labetalol, especially in IV form, right? So what are the practice points here? First dose hypotension. This drug causes a specific type of thing called first dose hypotension. Now, what is this? When you start the patient on alpha blockers, they will have this hypotension, right? Called first dose of hypotension, because they experience this when they take it for the first time. Now, later on, their body adjusts, right? And this doesn't take place much, but initially it is really severe, right? So and it is really severe in patients, more dangerous in people who are elderly, means old people, and also in patients who are taking diuretics. Now, diuretics causes excretion of sodium and water from your body, right? So what is it doing? It is causing what? Elimination of sodium and water, right, from your body, and decreasing the blood volume, right? Decreasing blood volume. If blood volume decreases, automatically BP will decrease for sure, right? So that's why both combined together can be dangerous, right? So that's why it should be what started with really caution in patients who are using diuretics, right? So see, to minimize first dose hypotension, what should we do? We should start with a small dose, preferably 1/3 or 1/4 of the normal dose. Okay, and it should be given just before the patient goes to sleep, before bedtime. Why? Because once the patient sleeps, he will not move around much, right? And once you start the drug in low doses, you can increase the dose every 2 weeks until the dose that you want reaches. Okay. Now, if somebody is taking diuretics and you want to start the patient on alpha blockers, what you have to do is you have to withhold this diuretic for a few days, right? And then start alpha blockers, right? Now, if somebody is on alpha blockers and you want to add another antihypertensive agent, you should do it very cautiously because the BP may fall really low, right? Okay. Next is an interaction. Now, we know alpha-1 blockers are what? Vasodilators. So are your nitrates and PDE5 inhibitors. What are they? They are also vasodilators only, no? Right? So when you combine a vasodilator with another vasodilator, what can happen? Severe vasodilation can result, too much of vasodilation can result in hypotension, right? Which can be dangerous, right? So when you add these drugs to somebody prescription who is already taking alpha-1 blockers, you should be really cautious. You may have to do dose titration. Okay. Okay, so we talked about hypertension. Another use of alpha-1 blockers is in benign prostatic hyperplasia, right? Now, it is a condition seen in elderly males in which their prostate gland, right? This prostate gland increases, right? Size of this prostate gland increases. Now, if you look at its position, where is it present? It is surrounding your urethra. Urethra is the tube that takes urine from your urinary bladder to outside. Understood? So now, where is this prostate gland present? It is surrounding the urethra, right? Completely, right? And through the prostate glands goes your urethra. Okay. Right. Now, so when the gland size increases, now what happens is the lumen of the urethra becomes really narrow, right? So there is urinary retention, urinary obstruction in these people, right? And they are not able to pee properly. Okay. Now, so what can we do? Right. What we do is we give them alpha blockers. Okay. Especially the alpha blockers which are more selective for the smooth muscle which is seen in your urinary bladder, right? So which are they? Tamsulosin and silodosin. They are alpha-1A blockers, right? This alpha-1A are the receptors which are seen on the neck of the urinary bladder. Okay, neck of the urinary bladder. So we said, what do alpha-1 receptor blockade do? It causes smooth muscles to relax, right? Relax. Now, if it is in blood vessel, it will cause vasodilation. If the same is present in your neck of urinary bladder, it will cause vasodilation in that area, and it will make the lumen wide, right? So the urine can come out easily, right? So they will be able to urinate properly, right? So that's why it is very effective in people who have benign prostatic hyperplasia, because the major problem in such people is there is resistance to urinary outflow, right? Okay. Now, so it is very effective regardless of the prostate size. Okay, and it gives you effect rapidly, and to get a full effect takes how much time? 4 to 6 weeks, right? So alpha blockers are first line. They're first line drugs for benign prostatic hyperplasia, right? Now, what is the actual cause of this? It is that your gland is increasing in size. So you have to prevent that from happening. Only then the actual problem will be solved, right? Now, there are another class of drugs which do this thing, right? Now, which are they? We have 5-alpha reductase inhibitors, example of which is finasteride, you have dutasteride, right? Okay, now what do they do actually? See, in males, the male sex hormone is testosterone, right? And in their body, it is converted to what? Dihydrotestosterone by the enzyme 5-alpha reductase, right? Now, this dihydrotestosterone, the more potent form of testosterone, okay, it goes and stimulates the prostate gland, and then prostate gland's size increases. Understood? The size increases. Now, so what we do here, we give drugs that go and inhibit this enzyme, right? And prevents the conversion of testosterone to dihydrotestosterone, right? Now you don't have the dihydrotestosterone to go and stimulate the prostate gland now. So what happens gradually? The size of the prostate gland starts to decrease. Okay, decrease. So it is very much effective, but the problem with this is to see any clinical response, it will take at least how much time? 6 months. Okay, it may take even more than that, right? So when you see a person prescribed with 5-alpha reductase as a pharmacist, what is your responsibility? It is to tell them that we have to do what counseling, the patient counseling. So the question comes, what you need to tell them when you see a patient on finasteride for the purpose of BPH, you have to tell them that you have to take this drug for at least how much time? 6 months time to see any clinical effects, right? So with antidepressants and all, it is what, 2 weeks time, right? So if somebody comes to you and says, see, I started taking the drug a week before. Okay, I'm talking about antidepressants, a week before, but I'm not seeing any improvement in my symptoms, right? What do you have to tell them? You have to tell them that you have to continue to take it for at least 1 more week, right? And then if you don't see any effect, only then you will have to go and see the doctor, right? Otherwise it is normal. Okay, right. Now, see, testosterone is converted to a more potent form, na? Dihydrotestosterone by 5-alpha reductase, right? So here it is blocked, right? And that's why these drugs can cause sexual dysfunction in males, right? Now it is contraindicated in women and children, should not be given to pregnant women because it is highly teratogenic. It can cause fetal malformation. Okay. Now another use, apart from its use in BPH, is it is also used to treat androgenic alopecia, hair loss, male pattern hair loss. And for that, the dose is 1 mg, right? So what is the major use of alpha blockers? It is its first line for BPH and third line for the treatment of hypertension. I hope you understood the topic. Let's do some questions. Okay, right. A patient with benign prostate hyperplasia started taking an alpha-1 blocker and reports dizziness and syncope after standing up quickly. Now he's taking alpha-1 blocker, right? He started it for BPH, right? But after taking it, he is feeling what? Dizzy, right? So the doctor decides to switch to another drug, right? Which of the following would be the best choice? So here you have prazosin, terazosin, tamsulosin, and doxazosin. What do you think is the best choice? So you can pause the video and try to give the answer. Answer is tamsulosin. Why tamsulosin? See, prazosin, terazosin, and doxazosin, they can cause vasodilation of the blood vessel and cause decreasing BP, which is responsible for the dizziness that we saw, right? But tamsulosin is more specific for the receptor, alpha-1A receptor, which is present on the neck of the urinary bladder, right? So this is more effective and it will not have much effect on the BP. Next, which of the following should patient be counseled when taking 5-alpha reductase inhibitors? Okay. So when a patient is on 5-alpha reductase inhibitors, what you should counsel them. Okay. Now, they reduce smooth muscle contraction in the urethra. 6 months of therapy is needed to achieve clinical benefit. Non-specific agents may also lower blood pressure. Common side effect is orthostatic hypotension. It is 6 months of therapy is required to achieve any clinical benefit, right? You have to tell them, otherwise they will not take the drug, right? After 2 months or so, they might stop it. We don't want that to happen. To increase patient adherence to the treatment, you have to tell them that. Okay, next one. A 58-year-old hypertensive patient was recently prescribed prazosin for blood pressure control. After taking his first dose at night, he reports feeling dizzy and nearly fainting when he stood up in the morning. What is the most likely cause of his symptoms? Why is he having these symptoms like dizziness and fainting? So what are the reasons? What could be the reason? Reflex bradycardia, first dose hypotension, rebound hypertension, increased cardiac output. Alpha 1 blockers can cause what? First dose hypotension, and that can lead to what? Dizziness, right? Falls, especially in elderly and all. It can also lead to what? Sometimes fractures, right? So to prevent that, what do? We give the drug at bedtime, and we usually decrease the dose to 1/3 or 1/4, right? Okay. So this was the class. I hope you understood. If you like the video, do give us a call. Thank you.